Hello, my name is Edoardo Aromataris from the Joanna Briggs Institute, and today with Anne Cheney and Kathy Granger, members of the Walters Kluwer Health team, we're going to tell you throughout this session some secrets of successful rollouts, and these are the secrets to the successful rollouts of basically evidence and evidence to inform decision making in healthcare and across healthcare organisations. So through this session, I'm going to start right back at the start, just very briefly, and a bit about evidence-based practice and why. Then move into the Joanna Briggs Institute, a bit about who we are and how we've gone about operating and really working in collaboration and in partnership with individuals and with organisations to produce and guide the production of resources that we actually do provide for members and users and who are looking to implement evidence in their practice and inform their decision making. And with that, I'm going to give you a little example, what I've called an evidence journey, about how, just an example of how we work with individuals and organisations to do exactly that. And I'm also taking a step back around some of the principles about what this is all about and about what really drives the Joanna Briggs Institute. Because one of the most important things about getting evidence into practice, and what I hope you take away from this presentation today, is that it really is all about collaboration and working in partnership. People have to embrace the idea of using evidence to inform their practice. And to make that work, and a theme that will come out through this, you really need individuals, we refer to them as champions or leaders in this field, who can really understand what it's all about and say, yeah, this is something that we need to do in our organisation. Because without that, it becomes incredibly difficult to really make change. And often that's what evidence-informed decision-making is all about. As the research changes and the evidence changes, sometimes practice has to change. And often people there who've been doing something for a long time, potentially in the healthcare setting, are often resistant to that change. So it really is a mindset. And these, for the first half of this presentation, I'll be talking about how we've operated, and also a bit about how that mindset has to operate and how that mindset has to change. And through that journey, what we've been doing over the years at the Joanna Briggs Institute, what we've learnt about what can help organisations and individuals do it a little bit better when we talk about getting evidence in the right place at the right time to inform their clinical decision making. And then for the second half of this session, I'm going to hand over to the two members of the Walters Kluwer Health team, Anne and Kathy, and I'll have a little bit to say there as well about 7 library-focused best practices for successful evidence-based practice rollouts. These are really some case studies, some examples, so you can see exactly what we've learnt over the years of working together about how we can facilitate organisations to actually get their hands on the evidence where they need it. So, as I said, we're going to start by taking a bit of a step back about evidence and practice and why is it important. It's really this realisation, some of this realisation is what spawned the Joanna Briggs Institute and other organisations like us. Essentially, evidence is essential because it assists health professionals in their clinical decision making, being able to provide that evidence. It enhances the ability of health professionals. This is so important to provide consistent and appropriate care. I've visited healthcare facilities where similar sorts of tasks are being dealt with in completely different fashions, just between different wards. Or certainly I might use within a single city or health system where different hospitals are doing things differently, simply because it's the way it's always been done. Or in one place you might find, for example, that they really have an evidence-based culture and they've embraced that, and you'll see what I'm talking about in a moment, whereas in another they may not. But ultimately the whole driving force behind this, and we often talk about that term best practice, is that the aim here is to improve care and outcomes for patients and clients across the board. Otherwise we wouldn't do what we do. That's what it's all about. Now, this whole idea of providing evidence to the right people in the right place where they need it, it's very difficult to be done by healthcare providers. Clinicians are incredibly busy, they're incredibly time poor, and those of us like me who work for these evidence-based healthcare organisations, we say you must be doing this. We stand here and we pontificate, it needs to be done. But it's easier said than done. There's information overload. As an example here, there are over 21 million records in PubMed, 700,000 went in last year alone. How do you Librarians, like yourselves for example, really have the skills to help these people find this information, but unless that partnership, unless that collaboration is formed around this ethos of evidence-based healthcare, it's really difficult for these clinicians, A, to find the time, and B, to have the know-how how to tap into all of that information. Many organisations have poor point-of-care access to summarised evidence. The computers might not be there near the bedside. And often clinical services and structures aren't routinely audited. So to aid in this, it's organisations, particularly on particular points, such as the Cochrane Collaboration and JBI, is really why we were formed to fill that niche or bridge that gap, if you like, between that world of research evidence and the world of clinical practice. But it's really difficult just to reach into it from here. And it's really good just to push it from there if you don't have the people on this side, the clinicians, and that bridge between the researchers to bring the two together. And that's really what this is all about. So how do we go about doing that at the Joanna Briggs Institute? Well, as I said, we are an organisation which is in the field of evidence-based healthcare, so across the health professions, not solely focused on medicine, as maybe the Cochrane Collaboration have certainly been in the past, but across the allied health professions and certainly in nursing. We're an international collaboration of health scientists. We spread right across the globe. The organisation was founded and located at the University of Adelaide, in Adelaide, and we're a not-for-profit, we're recognised as a not-for-profit evidence-based healthcare research institute. And we really have our mission and our vision is to improve global health, and to do so by providing point-of-care access to evidence databases, decision support systems, and implementation, evaluation and continuous improvement tools. Now, we do all of that, and it really is centred around this model which conceptualises things quite nicely. You can see right at the middle of that circle is evidence-based practice, and the three key things that it hinges on. One is, of course, the evidence, and certainly clinician judgment, and also client preference. And I'll start just in the yellow wedge, which is where we're aiming for, to improve global health. Now, in that purple wedge, you can see there's evidence, healthcare evidence generation. This is all the primary research, what a lot of PubMed, for example, Medline is full of. We don't do too much in there, but you can see some of the range of tools that are available in JBI at Ovid. There are some down here which can help with actual primary research undertakings. But most of the work, the real work that we do at the Institute, moves across the rest of the range of colours, the green, the blue and the red. And in the green, this is all about evidence synthesis and systematic reviews, which I'm sure many of you are familiar with, and we'll touch on again later in this presentation, and how librarians and champions again can work, and clinicians can all work together in terms of identifying topics and actually really conducting rigorous systematic reviews to then inform the rest of this cycle. So we have tools that can aid in the conduct of systematic review, and also importantly, we don't just stop there in terms of evidence synthesis, but another real important part of evidence-based healthcare, and really what we're all about in this field of, we call it translational health science, is being able to transfer that knowledge. And this is where we're moving into this blue zone, and this is where a lot of the products that are in the evidence-based database that you'll find in JBI at Ovid really find their home. Those evidence summaries are short snapshots now of a clinical question being asked, the evidence has been referred to, and here's the good oil, here's what the evidence is saying should be done in this situation. Now remember, one of the main ethos of evidence-based healthcare is that we don't just blindly follow the evidence. This is evidence-informed decision-making. But if it's presented there in that way, it makes it much easier for the clinician to then pick it up and decide whether this actually applies in this situation for this particular patient or not. Ultimately, they do have to make that final decision, but that should come into play. And moving from that idea of transfer, so we have tools that let you create your own manuals, for example, or even information pamphlets for consumers, but you can move into this all-important field of actually getting the evidence into practice and seeing that it makes some change in the process of healthcare, so what clinicians are actually doing, and also, ultimately, having some impact on patient outcome. And there are tools available here to help you record and monitor and undertake those sorts of processes within a healthcare facility. Okay. Now, as I mentioned, the Joanna Briggs Institute, the collaboration, we really are a global collaboration. And I just want to go into, as I said, these are some of the learnings from what we've been doing over the last 17 or 18 years, and working with these people all over the world. And the way we work in Adelaide and the way all of our collaborating centres work around the world is really quite similar. And it really hinges on collaboration. It hinges on partnership, it hinges on collaboration and partnership with clinicians and researchers, and really getting that one world to meet the other. So we don't just sit back in our home at our desks in Adelaide and decide what do these people need to know about. In many cases, yes, we do push knowledge out through all of our systems, but the way that knowledge is born, or where it comes from, is really those clinicians coming to us and saying, this is what we need to know, this is what we're doing, are we doing it the way we should be, what can you tell us about how we can be doing it better, are there better ways of doing this? So they're really pulling at us to say, this is what we need to know about. And that really facilitates exchange between both groups. So throughout this collaboration around the world, these real questions are arising in active collaboration, and we're providing really practical, we think, answers. These are the sort of things that clinicians want to know. And I just want to give you an example, as I mentioned, a little evidence journey of what's occurred in Adelaide. And obviously the Royal Adelaide Hospital, who we work very close with, they're our clinical partners, and many of our centres around the world have clinical partners they work in directly and have similar sort of interaction to what I'm going to describe to you here. In this case, it's a really nice story. A group of clinicians, these are nurse leaders across all different services within the hospital, so internal medicine, cardiovascular and cancer services, even general surgery, got together with a senior dietitian at the hospital because they realised that malnutrition, particularly in the elderly, was a big issue. Not necessarily what we call a fancy or a sexy issue, but it really was an important big issue, and they were having real trouble in the hospital related to it. We know that 40% of elderly people admitted to hospital arrive in a malnourished state, and 60% of them are unable to maintain their nutritional status while they're in hospital. And bear in mind that in large public hospitals like the Royal Adelaide Hospital, these elderly people make up a large number of the people who actually admitted on a day-to-day basis. So they decided, what can we do? We know we're not doing things right, and one of the first things they focused in on was the fact that they weren't doing risk assessments correctly. So they designed an audit topic. So this is right in that red wedge that you saw just a slide or two ago, about getting evidence into practice. And they decided to conduct a clinical audit about related to malnutrition amongst elderly in an acute care tertiary setting, and focusing in on how risk assessment was being conducted. And the aim of this evidence audit was really quite simple, just focusing on improving nursing nutrition documentation for elderly patients identified as being at risk, and also to ensure that elderly patients identified had appropriate nutrition care plans actioned following that identification. So what do we mean by a clinical audit? Well, the first step in the process is to turn to the evidence and say, what does the evidence say should be occurring in this case? In essence, that becomes the benchmark to which their processes are then measured against. And this was conducted across 5 wards in the Royal Adelaide Hospital, and they had 3 simple criteria using the JBI PACES, the Practical Application of Clinical Evidence System, which really is a system that's designed to facilitate the conduct of an evidence-based audit. And they had 3 simple criteria around screening and risk assessment of patients, elderly patients at risk of malnutrition. And here you can see the system really is designed to help across the tabs across the top here to set up a clinical audit, can help with the sampling, the data collection, and here on this screen we have an example of a compliance report. Now it's hard to see here, and these are the actual data that they came up with this team working in the Royal Adelaide Hospital, who turned around and said, we know we have a problem here, we want to do something about it. In other words, they're the champions behind this, they're the leaders behind this. how can we do this and do this in a systematic sort of way, a systematic evaluation of the process and what they do in healthcare. So they did baseline audit. Now you can't really see it, but the second bar will help. And then the gold line, you can see for the number 23, the second audit criteria, appropriate action plans are initiated when at-risk patients for malnutrition are identified. And that only occurred in 23% of their cases across the 5 wards. And you can see the first 2 criteria about using a validated tool and patients are being screened using a validated tool, there was no compliance at all when they started this. But through then moving on to what we call the GRIP cycle, this is getting research into practice, and this is really based around action research. The team and all the people that they get involved identify what the barriers are. Why aren't we doing this properly? What's missing? What do we need to be able to do this properly? And they start enacting some of that. And here you can see when they did the audit after that, and there were some simple things, I don't recall them all, but they found a validated tool, they developed a proper nutrition reporting chart, and they made sure that nutritional fluids are always available and handy for the nurses to get their hands on to provide for the patients. And also they did a whole series, I think over the course of a 3-week period, something like 120 nurses were educated in the use of these tools and what was becoming available to facilitate this risk assessment process in care. And what they found was when they audited soon after that, that they were up around 70%. So there's a real change in practice by clinicians who've turned around and said, how do we do this? How can we do this? How can we improve our care? And this is how the tools, a tool like this, in terms of getting evidence into practice, can help. Now this story is a really nice one because it doesn't just stop there. Through this process and really embracing evidence-based practice and the impact and how it can help decision making, change process and the like, the senior dietitian involved in this said, well, I'd like to do more. And she really took on that role as a leader. And what more did she do? Well, she had a question of her own. And so she came as a clinician looking to do some research. And the research was a systematic review, and I worked very closely with her on this, but it's about the effectiveness of mealtime interventions to improve nutritional intake of adult patients in the acute care setting. And there are numerous examples of this, and then we work closely with the librarians as well as researchers, systematic reviewers. You know, searching is so important, and it really does promote how information and information specialists and clinicians and researchers can all come together to bring this around full circle and really improve outcomes. But this story is really typical of how the sort of research that we do, the work that we do at the Joanna Briggs Institute, is driven by what's going in the research setting. Similarly, those evidence summaries, for example, that I mentioned that provide those snapshots for clinicians, well, if you get into your resource at JBI at Ovid, you'll see there that there's the opportunity to request a particular evidence summary if you go into the database and you can't actually find what it is you're looking for. Now, I mentioned right at the start, I'd just like to take a little turn now, because I mentioned right at the start that the key to this is really that organisations, if any of this is going to work, individuals and organisations need to embrace it. They need to appreciate that it's important, it's the way things should be done, and really take that turn to say, well, how are we going to do it now? What's out there? So just to take a step back, often, and what has occurred traditionally is that in healthcare and decision making, we generally do what we know works, the way we've always done things, and we're reluctant to change, okay? Irrespective of the fact there might be some better way to do it, but if we haven't looked at the evidence or the research, we're unlikely to know about it. But generally, there's very little reflection or critical thinking about practice, and the only thing that really triggers us or clinicians to turn around and say, okay, now we need to do something here, is if something goes wrong. But that's quite different to the way an evidence-based practitioner should behave. And these here the reference from 1995, actually been around a few years longer than that. The casily statement basically put into action said if you're an evidence-based practitioner, this is what should be taught to them, because this is essentially how they should behave. They should know how to convert information needs into answerable questions. So that's asking that all-important clinical question. Okay, but answering in a particular way that it facilitates them to track down the best evidence which to answer these questions. So they are a bit savvy about how to search and where to search. And quite different to the way a systematic reviewer would search, where conducting the research for a systematic review, I would normally start at the bottom of the evidence hierarchy, which many of you are quite familiar with the primary research. The clinician looks to start at the top with the evidence. I'm not talking about, sorry, the Ian Haynes 5S or the 6S system, with the clinical decision support systems. They're trained to find the good oil and find it quickly in systems like JBI Ovid or in UpToDate or and the like. They must have the skill of being able to appraise evidence critically. So even though it's scientific, even though it's research, even though it's published, we still don't believe everything we read, and they must take that critical mindset. And once they've discovered that evidence, what the evidence says, they need that ability to best determine how it should be implemented in their practice in that particular situation. And the final skill that an evidence-based practitioner should have is about evaluation of performance. And that might be in a systematic means, that it must be continual like a clinical audit, but also in a personal, reflective kind of way, that, you know, that they sit down at the end of the day or the end of the week and say, well, how many times have I actually done this? How many times did I ask a clinical question? How many times did I turn to the evidence in my everyday practice? Was it just when I was a bit stumped and was hit with something new? But in my everyday work, did I turn around in the sort of decisions that I'm making pretty often? Do I ever take the time to turn around and say, has something new been presented in relation to this? Because if they never make that step, well, then they never have the opportunity to actually find if there's something better way of doing things. So this is really the way an evidence-based practitioner now is essentially the consensus of how they should operate. But that's easier said than done, because what they need around them is an organisation that appreciates that and is ready to give them everything they need to be able to behave or practice in that fashion. And that's really what's behind all of those tools and also all the information that you'll find in JBI Ovid. It's all about providing point of care access to already pre-appraised evidence in those evidence summaries, those snapshots. If that's not able, an organisation, if that's not possible, an organisation should provide access to full text primary studies. Okay, and that includes systematic reviews, mind you. I wouldn't put systematic reviews in the pre-appraised bracket, but there are good systematic reviews and there are poor systematic reviews. Cochrane collaboration, JBI, we all have our own peer review process for these publications and this research, but that doesn't mean, just like what may be published in the Lancet, for example, just because they're high quality journals, it does not mean it is high quality gospel research. We need practice and policies available for an explicit evidence base, and established systems to audit practice and ensure practice is evidence-based, and systems to monitor outcomes and improve them. So you can make the match between what an evidence-based practitioner needs to do and what an organisation needs to provide to help them do all of those things efficiently and effectively. And that's really what JBI Ovid's all about. And using those collaborative processes and working with individuals and systems, you'll see we know we have systems here that help you access the evidence, so to search for that, summarise the appraised evidence. If you can't find that, there are tools like the Journal Club tool or JBI Rapid tool that help you appraise evidence and can work people, even novices, through the process of looking at research in a critical manner. And then certainly these last 3 points are about using the evidence. Tools to help use and ways to facilitate the transfer of evidence, so being able to create clinical practice manuals and also conduct clinical audits, just as an example. Now, we've done all of this, we know all of this, we've been working through all of this in a systematic way for many, many years now with our partners, with clinicians, with policymakers all over the world. But there are still some other little factors, despite all the work we try to do, that we've also learnt over the years and working with our partners at Walters Kluwer Health, that there are some other important things that really help facilitate this whole process. We know, for example, that clinicians, and this is evidence-based for you, clinicians will spend no more than 2 minutes looking for an answer before abandoning a search. Some quite interesting research has been done around that. The evidence needs to be provided at the point of care if it's going to be used. They're not going to walk down the corridor to find it and come back. The patients don't want to see that happen either. The clinicians don't turn around and say, don't go away, I'll come back with an answer soon enough. That's really not the way it should be working. And systematic review of these issues has shown that point of care access, easy to use point of access, does see significant practice improvements. So over all the years of doing this and knowing that, there are some little tricks that we've found about how to do it better. And when I say it, that is this use of getting evidence in the right place to inform practice so that people will actually embrace it, engage it, and it really does, because practice change is hard, it's difficult. If you can do these small little things, it can help make it easier, and they all are really important, rather than just saying, here it is, because most people won't do that. They need some help. And what do we know in our experience? Well, first of all, if it's made easy and accessible. So it needs to be where decisions are being made. That information needs to be at the bedside. In essence, we live in a technological world. Computers need to be available where possible. I know there are some facilities around the world who have thousands of computers. Others don't. And we try and work with those organisations, particularly in developing countries, about how we can present our materials in a different way, so that they can actually use that evidence, as long as it's contextualised and appropriate for them in their settings. But for the most part, for most of us, the computers, the access to the information needs to be right at the right spot. Besides that, we've found that, again, in how rapid you have to be to find the information, having a tailored landing page and providing access to these resources doesn't have to be just JBI at Ovid, but any resources that you librarians have decided that yes, our clinical partners should be using this, or within our hospital we should be using this, but getting it right, getting it all in the same place alongside each other, for example, so it's easy to find and it's right there where they need it and they're not going through page after page after page to find it. We're working with some of our partners in South Australia Health back at the University of Adelaide, and we're developing a desktop icon, so it's always there, every click on every computer. And often this stuff really works well if, when the patient information is up on the screen, that there are links to relevant information directly from there. There are some organisations which have managed to integrate this information into those systems really effectively. The other thing that is incredibly important with a system like this, but really any system. I mean, there are a lot of clinicians out there who could not necessarily search PubMed effectively. Okay, it really is an art and a science to a lot of what, for example, librarians like yourself do in terms of being specialists at finding information and using all of these different tools, many of which do the same thing. And we ask people who've never encountered this before to use all different platforms to search all different databases, for example. So it's really important, and this is again a part of that partnership and a part where librarians can become champions, for example, but to really work with people about how to find, clinicians, about how to find relevant information. And that's all about education. Now that doesn't necessarily mean that a librarian has to meet with every nurse in the hospital, but certainly the upper tier there of the nurse educators and the medical educators and the managers, so that they're all fully aware of what this resource is and how to make the most of it. Now that also branches off into the tools. I wouldn't suggest that a librarian needs to know how to conduct all the niceties of a clinical audit, but the principles of the tool and how it works. When you pair a librarian like yourself next to a nurse educator, you'll find how rapidly the knowledge, how it all comes together, and how the systems, just by virtue of what they're trying to do and get information from point A to point B, how they marry up really nicely with that sort of expertise in the same room. I keep coming back to this, and you'll see this now in the second half of the presentation again. A lot of these things that I'm talking about, both Anne and Kathy will touch on. And I will again when we speak about champions also, and particularly with librarian champions, but they're essential. If there aren't these sorts of individuals, and I'm talking about champions of using evidence to inform practice, then it will be a really difficult step forward. It would be almost impossible, I'd say. Someone has to turn around and say, hey, this is worth doing. But they're the sorts of individuals that, for a successful rollout, we've realised that we have to work really closely with them, okay, and really form a partnership, and not just us with them, but also those individuals within an organisation, because no one person can do it alone, and they really do come together in teams, and these sorts of people gravitate towards each other, so they shouldn't be too hard to find. But these who realise and embrace evidence-informed decision making, it is helpful, because we live in a technological world now, that they are a bit tech savvy, that they understand something about systems and playing around in computers. And another really important thing is, despite everything, that they need the time to be able to manage this and deal with this. And ideally, and I know in some places now, it's actually becoming a recognised role to really get evidence into practice. And here they, across these different champions or the like, they don't all have to be experts at everything. Some will have basic skills, some will have advanced skills, but so long as there's a mix and people are working together in collaboration and in partnership towards a similar goal, and we're all heading in the same place to improve patient care, then in our experience it's a recipe for success. So with that, now I'm going to pass over to Anne, who's going to tell you a bit about some of what the Wolters Kluwer team have encountered in working really closely with librarians in particular at different clinical sites and hospitals, about what they've discovered working really closely and touching on a lot of those things that I just mentioned, but showing you some really practical ways about how they've managed to do it and really promote the use of not just having subscribed to this information there, but really promoting its use and facilitating its use there at the point of care.
Hi, I'm Ann Cheney with Wolters Kluwer Health, a sales engineer. And I've been with Wolters Kluwer for over 10 years now, hard as that is to believe. And I also have a degree, a library degree, and over 20 years of experience in the library field. And we're going to talk a little bit about some of the best practices that we have found in working on implementations of our EBP products. So one of the first best practices is to put that product in context. And I think this slide talks about a lot of different concepts, but the concept for me is getting those resources out there for your users, making the users aware that you have them, making the famous two-click access. And that's what's really important. If they have to click through 10 screens, they are never going to get there. They're much, much too busy. And so one of the things that we've been talking about internally, and I'd like to at least propose for you, is when you have signed that contract and you're ready to start thinking about your implementation, why don't we set up a meeting and go through your current Ovid account configuration and look at how those new products or that new product will fit in. Maybe we can make it a little bit more prominent. Maybe we can make a few adjustments here and there to really make that transition, that implementation, more seamless and much more successful for your users. So we should make a meeting. You can meet with one of our sales engineers or perhaps one of our technical services staff who are a certified center of excellence, and they work very hard to retain that award rating every year. So we talked about, Dr. Daphne Stannard talked about, and Ed talked about, and now I'm once again going to mention how important it is to make that EBP information easily accessible. And so we can talk about maybe customizing your library, your Ovid library account. We can also talk about, obviously, sending you a link for your library page. That's always number one. But there are so many other possibilities, and that's my job today. So I was thinking about how, okay, you sign the contract for the Joanna Briggs librarian tools, or maybe for the Cochrane Database of Systematic Reviews, and you put a link on your library page, and you think, okay, now they're going to start using these products. Wrong. If you get it, they will not necessarily find it. You really need to get out there and make it part of their day-to-day operation. So, one of the suggestions we might make for you is a customized landing page. This was developed by my coworkers in Australia, and as you can see, we clearly start out with a little bit of branding for your institution, always a win. And on the right of the branding, we have two little search boxes. I hate to say it, I hate to use that term, but we do live in a Google age, and search boxes are a real comfort zone for your users. The other element that I really like on this page, and I don't see this very often on customized landing pages, is all these journal covers. Because this really tells your users about the resources that are at their fingertips. And we all know that a picture is worth 1,000 words. So other examples that we might suggest for you are search boxes. These, we call them widgets, but these are very simple search boxes. This particular one is nice because it starts with products that your users are already familiar with. They can opt to search Medline, PsycInfo, Psych articles. They can search those products together concurrently or individually, but now we're adding in the JBI database. So we're taking them from their comfort zone and introducing this new product, which is, I think, a very nice approach. This search box I'm particularly proud of because I worked with the American Society of Peri-Anesthesia Nurses on their implementation of JBI. This was probably about 18 months ago, and it was one of my first ones, so it was very exciting, and they were just wonderful to work with. So as you can see, we developed a search box for them. It takes a very small space on their society page, but you can see that there's a lot of content going on this widget. So up in the left-hand corner, we have a link to the JBI library on Ovid. They can jump right in and search if they want to. We also have that familiar Google-like interface, which is very important. And as the users start becoming more familiar with searching on JBI and the JBI products, they might start saying, well, I want to go directly to a systematic review or a best practice information sheet. And that is right here under the Publications tab. They can also limit by subject area nodes. So again, this interface really is everything they need in a very small amount of real estate. In addition to the search boxes, there are also links to each one of the tools, and we can customize one of these widgets for you to fit your tool, your JBI subscription. There are also links to the tutorials, to online help, and about JBI. So there's a lot going on in a very small amount of real estate here. And this is an example that I developed for a small community hospital in southeastern Maryland. I worked very closely with their EBP team, and I was so impressed with them that I came back and did a little search widget for them that does a concurrent search on both JBI and Cochrane Database of Systematic Reviews. And this is great because the two resources are complementary and there is no overlap, which is really important to know. And again, simple Google-like interface, and it delivers those resources, that results to them quickly and easily. Gets them using the product, and it's easy. This is another custom landing page that we did for the Rutgers School of Nursing. And again, it was just such a joy for me to work with them. This page, again, there's some branding for them, branding for JBI. The points on the wheel are all interactive links, and they love the page, and they've been using it for about a year now. So we were very excited to work with them. Now, we talked about widgets and we talked about landing pages, and this is something else that I wanted to mention very briefly. We have all kinds of collateral available to you to assist with your implementation. We have quick reference guides. We have the little flip cards on JBI. We have all kinds of database information sheets, and as you start into your implementation, if you don't find a particular type of collateral that you want or that you think would make a big difference for your users, let us know. We'll be happy to go and develop that for you. So I did mention earlier, and I wanted to show you, just give you that quick overview of the BrainShark and WebEx tutorials we have. We have them on a lot of different areas and topics in Ovid, and we have a whole page of JBI tutorials. The thing I like about these, and we all have ADHD, and therefore we need those very short 2 to 5 minute BrainSharks that give us the quick overview and give us that comfort zone in starting to use the tools and the JBI library. And these are great. Don't hesitate to pass this link out to your users. And of course, I'm sure this is something you do every day, but of course I wanted to mention it too. Market, 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 whenever, wherever. Develop that 30-second elevator pitch. Work on that 1-minute talk that you're going to give the clinician as you walk down the hall together. And of course, one of my favorite pictures is one of our librarians. She is Donna Flake from CHEC in North Carolina. And I think she does this every year. It's chat with the librarian, eat a cookie. And if you feed them, they will come. So now I just wanted to turn over to Ed.
Thank you, Anne. Another place where you might find yourself really engaging and working with clinicians is like that example I showed you earlier from the Royal Adelaide Hospital, where they turn their attention towards research, not just clinical practice. And often that research that clinicians are interested in, of course, is a systematic review. Not necessarily of course, but certainly when we're talking in the field of evidence-based healthcare, it's well aligned. And they really do, and the best recommendations are, we certainly recommend when, in the conduct of systematic reviews that we do, or when clinicians are working on systematic reviews, or anyone's working on a systematic review, that they really do work very closely with a librarian or an information scientist. There are skills, there are tricks, there's even some black magic involved, who knows, about how to make the most of those platforms and those tools and to find information efficiently and effectively. And it is incredibly important in a systematic review that that's conducted properly, but also that it's really well reported. There are international guidelines about how systematic review should be reported. An incredibly important part of that reporting is reporting of the search strategy. Any systematic review, just like an original primary research undertaking, should be reproducible. And the only way a systematic review can be reproducible, besides all the tools we use to appraise and the statistical tricks we might use to do a meta-analysis or statistical combination, we must be able to reproduce the search. And a well-performed and comprehensive search is essential in a review, and that it be reported properly in a review. Not just the search terms and filters used, but where the appropriate places to search, why there have been appropriate places to search, and also the dates that have been searched, the index terms that have been used. Any person who's looking at the quality of a systematic review will turn to that search strategy to then assess, and that will be a key factor in determining whether it actually fulfills the criteria for what is internationally recognised as a systematic review. And librarians really play, and information scientists play, a key role in helping researchers and clinician researchers get that right. Another place is, we spoke about champions earlier, I spoke about champions earlier. They're so important, as I just mentioned, in developing successful and reporting accurately repeatable search strategies. But also in some other parts, certainly within the systematic review process and the broader field of evidence-based healthcare, as I said, for evidence-based practitioners, in terms of being able to, for example, formulate and ask a clinical question. That's a skill that doesn't come naturally to all sorts of people, to everyone. And many clinicians, for example, might not have tried that before, and there's a unique trick to thinking and conceptualizing things in a way so you can align the way you ask that question to the concepts that are then used to search. You, as librarians, you're brought up with that. It's kind of embedded in you. But for many clinicians, that might be trying to teach an old dog a new trick, and they really do need to be worked through that process. And of course, they always will need help in identifying appropriate sources for evidence and to keep policy and procedure manuals up to date. So there's a broad range of areas where there's real synergy and potential for the librarian and the library. I'm not talking about the library where, you know, we used to think of a library with books on the shelf, but the resources that you all have available, and that you're really the conduit for those resources coming in and being available for that institution. For example, in this role as champion, recently at the State University of New York Upstate, the medical library has actually created a new role of clinical outreach librarian to really facilitate and to really clinicians moving into that field of research and into systematic reviewing and how to best manage and find the resources and evidence that they need to facilitate the research that they're doing. And now I'll hand back over to Anne.
Thank you so much, Ed. And we talked about the librarians and their role in working with systematic reviewers. I also would like to mention a recent addition for us, the Ovid PICO Resource Center. And no, this is not a librarian behind the page, but it does help those nurses, particularly I think, who went through the RN program, went through that 2-year program, because it's such a hands-on practical approach or program. They didn't get that background in doing research. And when they typically go back for the RN to BSN program and then maybe go on for the advanced degrees, they are the ones who just really need to develop their research skills to get more comfortable doing research. And a page like this is great because it steps them through forming that PICO question. It actually asks the question and you fill in the blanks, and then it does the search for you and returns fairly good results. Is it in place of a librarian? No. But it's just a nice way to, it's very approachable, easy to use. And one of the things I like about this is that it also includes PICO videos and PICO cards. So there's a little bit more going on there than just stepping them through how to form their PICO question.
Hi, I'm Kathy Granger with Ovid Technologies, Wolters Kluwer Health, and I'm one of the trainers with the training department. And I've had the privilege of working with several organizations, and I want to share some of those experiences and some of the successes that they've had in rolling out evidence-based practice from a librarian's perspective. You've heard from Ed about the evidence and from Anne about how to promote the evidence. Now I want to show you how to train the evidence and make that more evident to your end users and the people who are actually using the tools. In my experience as a trainer, I work with several different groups. I have the privilege of working with librarians who have been very active in promoting evidence and working with nursing councils and nursing research boards. And some of the organizations that have magnet status have different types of nursing councils that the librarian actually sits in the meetings every month and participates in the meetings. And I've been brought in to do training in those meetings. Most recently, I was at Baylor Health in Dallas and participated and did a training session for their nurses on the JBI database and implementing the evidence at the bedside. So again, Bonnie Arnold from Adventist Health is very active in utilizing the Ovid resources in the Nursing Council, and so these are just some different ways that I've been able to see how librarians really interact with the staff in both clinical and faculty and implementing the evidence. When we look at doing the training, one of the most important things that I found is in the first few minutes of the training session, it's really key to identify where the audience is. I found so many people sit in an audience for a training and they don't know what the training, they don't have the background for the evidence, or they don't have the background for understanding who Joanna Briggs is. So I spend the first few minutes really bringing their education level up so they're receptive to learning the information I'm about to train on. And if they don't know the content, then there's no conceptual knowledge development that happens from that training. So that's part of a big piece of it. The other big piece is really the pre-session thing that happens prior to my arrival. I do different things working with the librarians in promoting the sessions and promoting some of the learning prior to when the training actually happens. And then after the training, there's a post follow-up too. And shared with you some of the BrainSharks and some of the learning knowledge tools that we have as part of our learning resources. And those are some of the things that we use ongoing, both prior and post training sessions. These are a couple examples of the posters. One of them is really kind of neat because it shows how a library has actually advertised their resources, not the training per se, but the resources that they have available. The other one was a session that we actually did, and so I helped the librarians create the posters and then advertise the session to really get it visible. They use this both electronically and they post it throughout the facility. Probably one of the funnest things that I get to do is when I go to hospitals and I do training with hospitals, we've got a couple of different things that we've done on approach. And the librarian has been key in making this happen because she works with the nurse educators and schedules for me to go unit by unit. So I could be on a 7-story hospital and I'll start at the 7th floor and I'll go to every unit and do chair sides with the nurses and showing them exactly how to extract that evidence within 5 minutes out of the content. And it's been really successful, and the hands-on has just been a really big piece of being able to get the information in their hands. And they love it, and so I really enjoy doing those. The other ones would seem kind of funny. The doctor's lounge actually does work very well. It's kind of successful. I sit in the doctor's lounge, could be anywhere from all day to just a few hours, but really engaging them one-on-one, sitting them down in front of their computers and talking to them one-on-one about looking at the content either through Ovid or through our resources. And I'm amazed at how many of them really don't know it. And the librarians are too, because a lot of times in the hospitals the library is right next door to the medical doctor's lounge, and so not knowing the resources that they have and being able to put that in front of them is really big. And then again, probably the biggest piece of that is not only doing the chair sides and not only doing the office the doctor's lounge visits, but being able to really follow up with that then, and the tools that I provide the librarian post-training sessions, and being able to kind of keep that together. And it's really about the workflow. You know, I mentioned the doctor's lounge, I mentioned the nurse's station. I have a hard time standing in front of a group of nurses and expecting them to listen to me for 30 minutes when I've taken them away and out of their environment and interrupting their workflow. So this way I can be on the unit, I can work with them, I can talk about, you know, what patient maybe was recently presented with something that you had questions about. It's real life, it's much more livable for them, and then plus it has a much more sound knowledge development, if you will. So I really like that, and so the workflow is huge. So this is an example of a clinical decision support tool at point of care. And we have Oliver Tremblay, an RN, who's actually at a patient's bedside looking up the information through the JBI database, one of the best practice information sheets, and he's retrieved one of the algorithms that he's using at point of care with his patient. Some organizations have actually taken these algorithms and they're making them part of their everyday workflow in the patient's room or the nurse's stations, but these are all the tools and the support that that product gives them at the bedside. And we talk about training on a lot of the Ovid products, and JBI, of course, we really believe is a must-have, and especially the JBI tools. You can't implement JBI successfully into an organization unless you have training. And it's really important to do that from the very beginning and have that done in a way that is relevant to the users. And so I can't stress that enough, how it really becomes a must-have training situation. And I just want to come back around to some of the practices that we talked about at the very beginning, and regards to, you know, Anne had kind of pulled you through some of the context and how easy you need to make the information, and then understanding some of the requirements, and promoting it, actively promoting the evidence-based practice through the champions and through the different products and education. And I think we've really given you the fundamentals to driving the product and present the evidence-based products to the healthcare in their workflow. So thank you very much.